Good morning, everyone. I'd like to thank the organizers for inviting me to share with you years and years of trying to do point-of-care testing for STIs and what lessons we've learned, as well as what are the dare to dream scenarios that we will have going forward. Before I begin, I'd just like to say that I have no conflicts of interest to declare, and that the mention of any products does not mean that the London School endorsed them. So in terms of diagnostics, most people associate diagnostics with just to diagnose, rule in or rule out an infection. But in fact, I mean, there are many uses for diagnostics, and they all require different environments, as well as they are used for different purposes, such as for screening to determine the risk of progression to disease. And then after the person's been diagnosed, we need a test to be able to know the susceptibility in order to provide information for treatment. As well as for HIV, we needed the CD4 to initiate treatment until a couple of years ago. And treatment monitoring for HIV, viral load. And then for gonorrhea, quite often we have to have a test of cure. So all these different uses of diagnostics require different characteristics of the test, but whether it's we need it to be at point of care, it's not uniform. And so I think I would say that for most of the diseases, for most of the uses above the line, like for screening, determining risk for progression, or for ruling in and ruling out, it would be nice to have it at point of care. But more and more, we needed to have the susceptibility so that we don't just prescribe broad-spectrum antibiotics. So I'll talk a little bit about that. Now, so far, what kind of tests do we want for point-of-care testing? I think yesterday we went through the burden of STIs, and most of it is in the developing world where there are not many laboratory infrastructures. And so when I was at WHO, sitting at a donor meeting, I kept having to say what kind of tests we need. And I keep having to say, well, we need it to be affordable, sensitive, specific, et cetera, et cetera. So finally, at coffee break, I coined this acronym to represent the ideal characteristic of the test that we want. And we want it to be not only affordable, but also we want it to be accurate, but also very user-friendly and easy to do, so that we could do it at the point of care. So if you don't remember the acronym, remember the 3 A's of affordable, accurate, and accessible. Now, as far back as 1999, Dr. Ned Hook, who's here, and Tom Giff from CDC already looked at the benefit of having a rapid test. And they call this, the article that they, the study that they did, the rapid test paradox. And it's really to think about chlamydia testing. At that time, at Dr. Hook's clinic, they were using PCR. And so screening for chlamydia for women, the women have to return a week later to get their test results and treatment if necessary. And they were evaluating a rapid test where the results would be available in 30 minutes at the clinic. And so this is a modeling study to look at the benefits of that rapid test, and whether you would be able to treat more cases than compared to a laboratory-based test. And the results showed that a rapid test, even with a lower sensitivity of 65%, lead to more cases of infection being treated compared to PCR, if the return rate of the women were less than 65%. And also, by the time some of the patients returned, 3% of them had already developed PID. So that should have been a big boost for companies to develop rapid tests that could be used at the point of care. But sadly, I think there's been a lot of, in spite of a lot of investment, regulatory approval was very slow for new technologies because the paradigm for approving a test has always been based on the drug paradigm of never approving anything that is not equal or better in performance than the predicate device. And so the company OraSure told me that it took them years and years of advocating with the FDA to get their oral test for HIV approved. And in this table, I could show you that for the over-the-counter use for HIV, the lower bound of the confidence interval for sensitivity of this oral test was below the recommended performance that is posed by the FDA. And it took them a lot of time and also effort with the modeling study to show that if a new HIV test for oral test is approved, then more than 2.7 million more people in the U.S. would screen for themselves for HIV, out of which we could probably avert 4,500 infections, and that is a benefit, public health benefit, that outweighs the individual risk of maybe 1,100 false negatives. But I think that we continue to have a very slow regulatory approval process, which we're trying to work on now to try and get new tests approved more quickly. Now, what do we have at the moment? We did a systematic review. It was contracted by the WHO of point-of-care tests that are commercially available today. We have rapid treponema tests that are based on either whole blood or serum or plasma, which performs fairly well, medium sensitivity around in the 80s and specificity in the 90s. And although these don't perform as good as the rapid HIV test, it's really a biological phenomena and not because the technology is not good enough. Syphilis just does not elicit as much antibody as HIV or HCV. So that's why we don't actually have an oral test that we could use alongside HIV and HCV. Now, unfortunately, for antigen detection tests, lateral flow rapid tests don't perform as well. And so the performance is for vaginal swabs in the 30s and for endocervical swabs in the 50s. Now, you may say, well, 50%, that's like tossing a coin. But in terms of public health, we need to think about the fact that actually the test is identifying the 50% of the population, of the infected population, that actually has the highest bacterial load. So maybe even using those tests in specific high-risk people may be useful. Now, what lessons have we learned from implementing point-of-care tests for STIs? Because rapid syphilis tests perform well enough, acceptable enough for us to go ahead with implementing it in different countries, we were very fortunate to be funded by the Gates Foundation to try to implement rapid syphilis tests for prenatal care primarily in 7 different countries that have very different cultural, political, socio-economic situations. And they are Brazil, Haiti, Peru, China, Uganda, Zambia, and Tanzania. And what we've learned from those, the first lesson that we've learned from those, is because when you take testing out of the laboratory, you're now in many, many communities that are different from each other. So it's really important to engage all the stakeholders. And also because when you introduce point-of-care testing, a lot of the laboratories are going to be really, some are frankly hostile. And so you really need to dissipate the tensions between all different parties and identify champions. And the training also has to be culturally acceptable and based on the basic knowledge of the people who will be doing the tests. Because these are not trained technologists, and so on. So there's a list of 7 things, including integrate with other services, which WHO is really championing right now, is to integrate different services that are silos into an integrated platform, especially for testing. Now, I show this picture. The picture below of us testing in the Amazon forest in Brazil. And acceptability is no issue. Introducing the tester is no issue. Even training was okay. Our difficulty was that when after the provider has performed the test and we lay it down to wait 15 minutes to read the test, the monkeys will come and steal our test. So we have to protect the test from the monkeys. So that's one of the lessons learned. Now, lesson 2 is that we found that by having this rapid test, we've actually improved the efficiency of healthcare systems so that women have to no longer come several times. In Peru, it's actually 6 visits in order to get their testing and treatment. And so it's really a chance to catalyze health system strengthening. Lesson 3 is when you take testing out of the laboratory, quality assurance of the quality of the test and quality of testing become really important. And so we did a costing study, and we found out that actually even with testing being done in thousands of sites across the country, that if you use dry tube specimens, which CDC had developed, and either the supervisors take them on the rounds of all the point-of-care testing sites, or you mail them, the costing is for an external quality assurance program is only about 15% of the entire testing budget. So it's really should be included in the budget for a point-of-care testing program. And so together with CDC and WHO, we actually published this booklet on improving the quality of HIV-related point-of-care testing programs. Then the final lesson I'm going to share with you is that if we compare introducing syphilis testing into many countries to introduction of HIV point-of-care testing programs or malaria, we found that although the accuracy is acceptable, so I'm now going back to the 3 A's. So accuracy is acceptable. We have accessible tests that could be easily done in all settings for all 3 diseases. And yet the difference between HIV, malaria, and syphilis is that syphilis do not have the kind of donors that HIV and malaria have. I think the Global Fund for some countries will allow the countries to buy syphilis tests along with their HIV budget. But what is really different is that we couldn't sustain the syphilis testing program for prenatal care in many countries that have started to do this as a pilot, because even though every country has a policy for screening pregnant women for both HIV and syphilis, is that for syphilis we don't have the architecture that of a national program that would provide the coordination, the procurement, supply chain, training, quality assurance, and M&E. So this is really an important lesson to learn. But of course, we don't want to create an architecture for every single disease for point-of-care testing. And that's why integrating different services, it becomes very important. So now, what do we hope that we could have in the future? Some things are already rapidly evolving. The WHO, the Reproductive Health Research Program, has started a point-of-care initiative. In fact, one of the first things that they did was commission a landscape of point-of-care tests that are currently available as well as in the pipeline. They contracted us to do systematic reviews of the performance of these commercially available tests. And then we set up with WHO a network of evaluation sites where we already have generic protocols that are approved for use in all the sites. So when the tests are available, they could immediately be evaluated, and we don't have to wait for a couple of years to negotiate a testing protocol, wait for ethics approval, etc. And at the same time, we work with the country programs to think about the translation of into policy using models, etc. So this is ongoing. And we're looking at a multiplex tests where we could integrate services. And we do have HIV, HCV, and syphilis as one test. And these all perform quite well in terms of both sensitivity and specificity. And they can be done at point of care. The ChemBio test, in fact, now has a little reader that you could click onto the window of the lateral flow test and read the test so that you no longer have subjective reading. We found out in our Peru study that about 11% of the healthcare workers actually are nearsighted but didn't know it, and so they couldn't read the line very well. About 7% have degrees of color blindness, and because the lines are red, and so when you have a weak positive, they cannot see it very well. And so having a reader really helps standardize the reading and overcome all these problems. We have now ongoing evolution of models of more client-friendly services based on point-of-care testing. And I just want to note that for the Dean Street clinic that was started in Soho in London, which provides a rapid anonymous testing based on the GeneXpert platform, that's been done really well, and it's very client-friendly. In fact, you come into the clinic and you input your information and why you want to come here on a computer, and the computer would direct you to a room where specimens, you are instructed on how to take specimens through a video, etc. And so it's very, very user-friendly, and because the test result could be ready in an hour and 45 minutes for chlamydia and gonorrhea, you could either wait or you could go back to work and your results will be on your phone and you'll be directed to what to do next. So these are ongoing models, and I'm sure there are many others. The Dean Street clinic model is being replicated elsewhere already. Now, there are also phone-based diagnostics. At first, we used to use phones to try and read the rapid test, but now there are about 6 different groups looking at using the phone to power the test reaction, as well as read it and then transmit it to a central database. So in the picture here, Professor Sam Sear from Columbia University and his team developed the dongle that can plug into the power jack of the phone, and then there's a microfluidic disc, which is very cheap to manufacture. It's inside, and he's replicated the entire ELISA procedure in this microfluidic disc. And you could, with a very small volume of blood from a finger prick sample, in 15 minutes you could see whether there's HIV and syphilis antibodies. So these are rapidly evolving. There are phone-based molecular tests that are available. So you can imagine you could do HIV, HCV, viral load there as well. And so these are evolving very quickly. But one thing that would be very nice is that with the convergence of digital technology and point-of-care tests, that is now possible to have automated surveillance, and also in the developing world where supply chain is always a problem and we constantly have stockouts of tests, that this can be used to have alerts when stocks are running low, and also be used to monitor performance of the machines. Because you can imagine that with point-of-care machines being deployed to thousands of sites across the country, it's very hard for the Ministry of Health to keep track of how well the machines are running. If they're not running, how do we know, etc. And so these are dashboards that you could already create to monitor the machine performance in terms of error rates, whether they're working or not, and also monitoring supplies. And so finally, the Dare to Dream scenario. If we were able to have a rapid test that could be done at the physician's office to identify gonorrhea, but not only the pathogen, but also either susceptibility or genetic markers, then in the UK, in 2014, they conducted a survey to see how many of the GC isolates that they have are still susceptible to penicillin and ciprofloxacin. And what they found was that if such a rapid test were available, then 66% of the current treatments for with ceftriaxone could then be switched to ciprofloxacin. And 79% of those treatments can be substituted with penicillin. So having this Dare to Dream kind of test, which we call AMR POCT, can reduce loss to follow-up because you no longer have the patients come back, extend the life of the current last-line treatment for gonorrhea, and is cost-saving. And so in summary, I just like to say that lots of things are happening, and we have lessons learned from point-of-care tests that we could use to apply to point-of-care testing in the future. And there are many exciting technologies available. We need to get them into use as soon as possible, including tests with susceptibility patterns. Thank you, and I'd like to thank my team and all my collaborators for a lot of the work that I mentioned. Thank you.